Welcome, Dr.
I'm Lenny.
Mandelberger, to the Alloy platform. I'm
Thank
going to
you.
introduce you and just sort of lay out what we're talking about today and then get started with questions.
Perfect.
Dr. Mandelberger is a board-certified OBGYN, fellowship-trained minimally invasive gynecologic surgeon, and certified menopause practitioner. She is the founder of Balance Medical and All Things Menopause. She obtained her undergraduate from Cornell and medical degree from Tufts. I'm skipping a lot of your very impressive
Please.
bio and leaving us all with the fact that you live on Long Island with your husband and 2 children. We're so happy to have you here. Today, we are diving into a topic that more millennials should be aware of,
Yes.
perimenopause. For one thing, I guess what I was thinking about when I thought about this conversation is the fact that so many people don't realize that perimenopause and menopause truly is a transition. It's
Right.
not something that happens overnight,
Right.
and it can start in your late 30s. So I
Absolutely.
guess to sort of just clarify the basics,
Yeah.
Dr. Mandelberger, if you would let us know what perimenopause is, let's start there.
So it's a great question because it's sort of a fuzzy definition, to be honest with you. There is one sort of defined strategy for classifying all the reproductive stages. It's called the Straw 10 criteria, where a bunch of academics got together and together decided on different criteria on how to classify menopause and the reproductive ages and perimenopause. I have to tell you, it is extremely complicated.
Yeah.
Even I don't really use it
I've
because
never
it's
heard of
terribly
that, the
oh,
straw 10
I don't know.
criteria.
I personally, I don't find it that clinically relevant for most because I treat the patient on symptoms, right? And not based on, oh, you have not met this exact, you've hit this stage, but not that, therefore I can't treat you. I don't treat that way. But
Right.
technically, according to the official definition of perimenopause, it begins when you have 2 consecutive menstrual cycles with a greater than 7-day variation compared to your normal cycles, with a whole bunch of caveats, being that doesn't apply to people that don't get menstrual cycles, whether that's from a hysterectomy or from an IUD or from other reasons. It doesn't apply to women that have a history of abnormal cycles, such as if they have PCOS or other reasons for having abnormal cycles. And so it is definitely with some flaws. So that's technically the beginning of perimenopause based on their definition. And then it ends 1 year after official menopause. So that would be 2 years after the final menstrual period. Now, I would say, the clinical world, at least in my clinical world, I use a bit of a broader definition. So what comes before this perimenopause, according to the Straw 10 criteria from the Menopause Society, is the late reproductive stage. So you're still a reproductive age woman, you're getting menstrual cycles, but things are starting to change. Things are starting to change hormonally, whether you are experiencing symptoms or not. And so, sometimes may or may not show up in blood work, which we can talk about if you wish, but you might be feeling some mood changes. You might be having very subtle changes in your cycle, or very, very subtle, like maybe suddenly your PMS has gotten worse if you experience PMS. So I personally use a broader definition than the technical definition, which is you're entering your sort of late reproductive age and you're starting to feel symptoms. So for me, it's when symptoms begin and hormone changes begin together, and goes into sort of I agree with the 2 years into menopause, 2 years after the final menstrual period, approximate definition.
Okay.
It's sort of this most tumultuous time when it comes to hormone changes.
Thank you for that. So I'm thinking about someone in her late 30s, maybe early 40s, late reproductive stage.
Yes.
And she comes to you for her annual.
Yep.
And you ask her how she's doing, and she's sort of like, I don't know, maybe a little of this, maybe a little of that, but she's not having changes in bleeding,
Right.
and she's not having mood swings. Maybe she's feeling a little blue or a little anxious, but her skin is itchy and her ears are itchy and her eyes are really dry and her hair seems
Right.
like it's falling out. And she's sharing these things with you. So I guess what I'm asking is, what particularly stumps patients that you see, or stumps millennials in perimenopause that you see commonly?
Stumps in the way that they don't recognize it as
Yes,
perimenopause, you mean? Yeah. So
exactly. Yeah,
constantly, I see this patient multiple times every single day.
yeah.
So so the first thing is very, very often, if they're not already my patient, and these days I am seeing annuals, but I started a new practice, and so I'm seeing a lot of consultations that have come from the outside where they're having care elsewhere. And very frequently these patients are told they are not in
Right.
perimenopause. They are not in perimenopause. I'm not sure what these people are basing it on, whether it's this official criteria, given that their cycles maybe are still, regular, which they're not wrong, but it can be very dismissive. And that maybe they did hormone testing, and the hormone testing was not consistent with menopause, by the way,
Mm-hmm.
because
Mm-hmm.
that's really the only time that we can, like, this is what it really shows. It's, when you're in full menopause, there's consistent hormones, so consistent, the testing will be consistent. In perimenopause, the hormones are up and down.
Right.
1 month it might look like a 25-year-old, and then the next month it's going to look like you're in full-blown menopause.
Mm-hmm.
And so often I have patients come to me being told that they're not in perimenopause, and so that leads them to believe their symptoms have to be due to something else. And so I think that's the greatest thing. And because, as we probably know, as our listeners here probably also know, there's such a wide range of symptoms that can affect women during the menopausal transition, which is my preferred term, by the way.
Okay. Good, great.
I
Could
just think it's
you
like,
unpack for us
yeah,
some of those symptoms? I saw someone said frozen shoulder and itchy ears,
yeah,
maybe. Can you start a little bit about that? And then I have another
yeah.
question that came in for you.
So I like to think of big categories. So I'm a how do things work kind of person, and so I like to think back as to, okay, could this be a symptom of perimenopause? Well, what is actually happening and to the hormones in this time frame, and how can that show itself? So one big class of symptoms is cognitive slash mood symptoms, and this is incredibly common. We see changes, like I mentioned earlier, very frequently just before and in the beginning parts of the period when the estrogen levels are at their lowest. That is usually when these symptoms happen. Also, I tell my patients that you can be triggered by mood symptoms as the progesterone levels drop as well, which is also just before the period. And so that would be one big class. So depression, fatigue, brain fog, ADHD symptoms, so inattention, irritability, rage. We get a lot of people talking about rage, and memory loss is a big one, especially
Mm.
verbal memory. I have so many women coming to me thinking they're in the early stages of dementia, which is a very scary thing. So that's one class or category of
Mm-hmm.
symptoms, basically brain symptoms. Of course, there's also hot flashes and vasomotor symptoms, which that typically is more
Right.
recognizable, especially if it's severe. I mean, most women, that's like the basics, right?
Sure.
Menopause, hot flashes. Most women
Yeah.
know that, and so that is less of a stumper. So we'll put that in its own sort of separate category. Other big category, which is big category, is the fact that estrogen acts in our bodies as an anti-inflammatory.
Mm-hmm.
And so when our estrogen levels drop, any condition that is an inflammatory type of condition can reveal itself, get worse, and all of the above. So things like musculoskeletal syndrome,
Yes.
like the frozen shoulder, or joint, other just general, like maybe the earliest stages of arthritis, but suddenly those joints are inflamed because of the lack of estrogen. And I very commonly see patients that have, this doesn't happen to everyone, but patients that have a history of an autoimmune disorder.
Yes, I'm
Suddenly their
seeing a lot of that here
symptoms
pop up.
are getting much worse. Their
Okay.
autoimmune disease, and they're asking their autoimmune doctors, whoever's taking care of that particular condition, what is going on, and they're not getting the answers. Other things, what was I going to say about the inflammation? I had something, I lost
It's
it, but
okay. I'm sorry.
those are the
It's my
big
fault. Okay.
verbal memory loss. Um,
Oh, you were talking about the sort of big categories. So
yeah,
cognition, mood, inflammation. Is there another big category that you typically identify to, as the umbrella to perimenopause symptoms?
so those are big ones. Oh, I was going to say the inflammatory. I was going to say IBS. That's
Okay,
where I lost.
okay.
IBS is a very common thing that I see because it's a common condition in general, and it tends to flare around perimenopause. I see that very frequently. Um, and then so inflammatory conditions, cognitive and mood changes. At almost, I mean, because of the inflammation, that's a big one. And metabolic would be the third category. So a very, very common complaint is, I mean, we all know this, right? That's the other thing that everyone sort of either feels themselves or is aware of, is that we gain weight, or we
Right.
have difficulty losing the weight, especially around the middle. And
Yes.
so many women coming feeling really disheartened because they're working their butts off and nothing's happening. There was a really interesting lecture at the Menopause Society a couple weeks back about metabolism in menopause and perimenopause, and it's really kind of a bummer, but and I don't want to push anybody into calorie deficits, don't get me wrong, but our daily caloric requirement because of the metabolic changes decreases. And
Decreases.
so it is absolutely true. You are not going crazy, that you have not changed a thing. You're doing the same things, eating the same amount, exercising the same amount, and you might gain weight because unfortunately our total caloric requirements and our basal metabolic rate has slowed. And so
And doesn't
it's going to make those changes
also
happen.
sort of where the weight is distributed
Absolutely.
changes as well. Can you speak about that a
Yes.
little too? Because I imagine, for someone in their late 30s, early 40s even, who has a real sort of fitness routine and a nutritional profile that they adhere to, and suddenly they're gaining weight or retaining weight, it just seems to
Yeah.
be like, what's happening in my waist. Can you talk about that a little bit?
Absolutely. So this, I will say it's not everybody, because some people
Hmm.
find their typical weight distribution versus the change. And I think it probably depends on how far along and also the relative amount of androgens that we have. So we tend to get more of what I call an androgenic weight distribution, which is, instead of where we used to put on maybe around our hips and our butt, which like we don't mind so much always.
Yeah,
Now
well, it
it's
depends on who you
going,
talk
some
to.
people do, some people don't, but like maybe somebody didn't in the past, but suddenly it's on their bellies and this is
Right.
a whole new body for them.
Yes.
And so I guess whether they mind it or not, it's a feeling of, my body is changing, and it's frightening and it's frustrating when you don't know what to do about it. So it's often around the middle, both in subcutaneous distribution, so actual like belly fat on the outside, but also you do get an increase in visceral fat, which is the dangerous fat surrounding the organs on the inside. So the sort of like beer belly or gut that just like, it doesn't feel fat, but it's a more stiffer feeling, that can start to protrude. That is a somewhat of a later finding, but if you look at body compositions, there often are those subtle changes that
Right.
might not be noticeable on the outside, but as the metabolism changes in menopause, you do see those slight increases in visceral fat.
Someone asked about insulin resistance, which I know
Yes,
is something that also often
yes,
increases for women. Can
absolutely.
you talk about that a bit?
Sure. I mean, it's huge. It pretty much invariably increases. So two things, I always like to look at my patients' blood work, and I'm not talking about
Right.
hormones. I'm talking about their primary care
Hmm.
blood work. I want to see their lipids, and I want to see, which is cholesterol levels basically, and I want to see their hemoglobin A1C, which is a measure of um, diabetes, or how your body is processing sugars. And while my patients will be like, they were fine. I'm like, no, please show me.
Yeah.
Please let me look at them, because maybe they're still in the normal range, but they're
Yes.
creeping up. If you compare it to the prior, you will almost invariably, I would say, if anything, that's like the first tell of perimenopause? It's a good question that we're bringing this up, because
Yes.
this is one of the first findings that I see, is that the lipids, especially the LDL, starts to creep up. Okay, actually the HDL interestingly goes up too, but the LDL will start to creep up, which is what we call the bad, I hate these terms also, but bad cholesterol. If you follow more of a comprehensive panel and you follow your apolipoprotein B or ApoB levels, that is a totality of the bad cholesterol or the bad lipid particles in your blood that will also rise. And again, it might not rise to the abnormal range, but it's rising, and it's a sort of direct correlation with the increase in those levels and cardiovascular risk. So those will rise, as well as your hemoglobin A1C is going to go up. So again, you might not be pre-diabetic or diabetic, or you might suddenly be pre-diabetic for the first time. I see this in my thin, healthy, exercising, eating right women constantly, and it's like, what is going on?
Happening?
I'm doing the perfect lifestyle. It is so frustrating to them, and even me as their physician. Like, they're doing all the right things, and suddenly they're pre-diabetic. It's the hormones. It is the hormones causing the insulin resistance. It is incredibly potent effect. And really
Dr.
kind of a bummer.
Just it is, just to hover on this a little bit. I'm seeing a lot of questions. Some questions came in about cholesterol, protecting the heart, my levels going up. I'm pre-diabetic. I'm recalling. So I'm 54 now. I began to experience symptoms in my early 40s. I was probably perimenopausal earlier than that.
Right.
I also had blood work come back that showed that my cholesterol was going up and all of the things you spoke about. I was hovering in this pre-diabetic. I didn't want to take medication for it.
Right.
I began MHT, and everything settled back into a happier place. Can you talk about that in terms of also women who are still menstruating and sort of what their options are then?
It's tricky.
Yeah.
It's tricky. So women who are still menstruating, first, I don't want to, we'll talk about MHT for sure, but I want to be very, very clear that it's not a magic pill, right? It's not like that's all you need to do, and it's going to correct all of your metabolic derangements. I mean, the food that we eat, the exercise that we get. So the number one most important, well, I can't even say one. I can't pick a child. It's sleep. Right. It's it's sleep. It is exercise in the form, especially of resistance training.
Okay.
You want to try to build muscle. Muscle, physical muscle cures insulin resistance. Not 100% for everyone, but it can cure insulin resistance. So the more muscle you have, the better able you are to process sugar. And the more muscle you have and the more muscle you use on a constant, regular basis, again, the better able you are to process sugar. So that is hugely important. Stress, okay, cortisol rising is an amazing effect on your blood sugar. Okay, the more cortisol you have laying around, that sugar is going to spike. Your body thinks it's ready to it's ready to run away from the lion, right? That's always the classic thing. And it's going to need lots of energy in the form of sugar, quick energy, to get that done. But we're not running away from lions. We are comparing ourselves to our peers. We're looking in the mirror. We're worrying about our kids and our parents. And that doesn't just like run and then go away. So stress reduction techniques, sleep is crucial, okay, to reduce our cortisol. So the classics, right? Diet, nutrition, exercise, and sleep is number 1, 2, and 3 at equal levels, must. Okay, and then in the diet, you want to focus on anything that's going to support healthy muscles. So, pushing the protein. And also, this is I don't want to go too deep into this because we don't know too deep into this, but, gut health is really important. We're just scratching the surface on gut health and the microbiota. So anything you can do to try to support that. Right now, probably the best thing we know is fiber. So
for sure. Dr. Mandelberger, you sort of laid out in answering now, my next question was about how can millennials, and sorry I keep using this word, but that's really who we're talking to, but what can millennials do now to prepare their bodies for perimenopause? So whether they're in it and not symptomatic quite yet, or
Right.
about to be. So you talked about exercise, particularly strength training, eating a high fiber diet, stress mitigation techniques,
For
sleep. Is there
sure.
anything else that resonates for you?
So yes, I mean, I always say, like, you got to build the muscle, you got to build the muscle, you got to build the muscle. But I'm going to take this a slightly different way than I think you're asking, but I think it's incredibly important. I think
Great.
the very best thing that millennials can do for their bodies right now is educate themselves.
Tell us more. Great.
Educate themselves, because knowledge is power, right? I mean, we all know this crazy world we're in, where we're people are just finding out like menopause is a thing, even though it happens to 100% of women that live long enough. What's that about? Like, oh, by the way, we should probably pay attention to this in science. Okay,
Right.
great.
Right.
Good,
Right.
good idea.
Yeah. Great. Good
Um,
thinking, guys.
uh, so so we're playing catch up. We're now playing catch up, right? We're trying to figure this out. We have this whole movement going on. We're trying to put it out there, but we are definitely playing catch up, including physicians. The vast majority of
Yes.
physicians still are not educated on this. And while that's a big movement, there's also, I heard Kelly Casterson speak on this at the Menopause Society the other week, and it was just, I love the way she put it. It's like, we have to have a grassroots movement
Yeah.
where women themselves are educated. They go in knowing, I don't want to say 100% what they want, but they are educated enough to have a discussion with their provider and have an idea of what they want while keeping an open mind on a hopefully educated provider. And we're going to force the medical community to learn
Yeah.
about this, because if every patient is coming in asking about it, the doctors are going to have to learn.
I have to
Um,
say, I feel I take this statement super personally, because as a woman who just went looking for answers,
yeah,
I feel like that movement has propelled medicine to join us in the room. There are
absolutely.
so many women on this social media platform alone who are kind of like, what's going on? And I need some answers, and I
Menopause.
don't want to do that. Right. That doesn't suffice. And
Right.
I think, the dream, or certainly the what can happen, is that across specialties
Yes,
there will be,
that's the biggest
you
thing.
know,
It's
reg
not just an OBGYN
it's not
problem.
just an OBGYN, it's madness.
Yeah.
So yeah, I appreciate that. Go on. I apologize.
I mean, I think that's the biggest thing, is that we go in, the patients need to go and educate. Oh, what I was thinking of is that the Menopause Society blew up, right? They were way
Yeah,
over, like, they sold out, and I think double the amount of people, physicians and other practitioners, wanted to come. And so it's happening, but it's like, we still have a lot of work to do.
sure.
So it's really exciting.
Dr.
But
Mandel.
women my age have to educate themselves
Yes,
on their
yes, yes.
bodies and not deny changes. They are going to come. They are going to happen. Not everybody's going to have a difficult time. Not everybody's going to have terrible symptoms. It's not all doom and gloom, but you are going to go through menopause. And so if you're in your mid to late 30s and early 40s and you're experiencing any kind of change in your body, whether it doesn't seem like it might be related to menopause or not, like, explore that as a possibility and question your medical professionals on it, because I see so many patients, like, not wanting to come to terms with the fact,
Do
and
you? I was
everybody,
just going to
it's a hard,
ask you, can you
all the
expand
time.
on the denial
There's
comment? That's
a
interesting.
lot of denial. There's a lot of denial.
Really,
I mean, people are afraid of aging. It makes sense, right? I mean, we see our parents and grandparents in nursing homes and, soiling themselves and not cognitively there. It's scary.
hmm
Aging is scary. But what makes it less scary is knowing how to do your very best. Like, we have some control. We don't have all the control in this, right? There's genetics, there's chance, there's just inevitable things that will happen. But we do have some control in how we live our lives and how we treat ourselves. And so, knowing your risks, knowing your options, and knowing what's treatable versus not is really powerful. And then, you don't have to just suffer. I'm
Yeah.
going to be honest, I shouldn't even like say this, but like a family, I won't say who it is, but I have a family member who's struggling and she just doesn't want to listen to
Yeah.
me. It's just like,
Yeah.
I'm like,
No, we see that all the
perimenopause. She's like,
time.
no, it's not. I don't want to hear about it. I'm
Now,
like,
Dr. Mandelberger, I want to just kind of spend time for a minute on options, because just sort of getting back to my last question, a woman in her late 30s, early 40s, she's still menstruating. Maybe her periods haven't really changed yet. She
right.
needs to worry about birth
Yeah.
control, and she has a shift in her hormones. And I'm so grateful that you highlighted sort of the silos of health, right? That millennials need to be aware of, considering, conscious of, sensitive to before they hit this transition. But then there's the hormone piece. And I agree, although it's not a panacea, it's this first
It's
line of defense for
it's
many women.
big.
And
It's big.
certainly,
Yeah.
yeah, I mean, it's like
Incredibly important.
yes, it's all of what this conversation is about. So could you sort of lay out what the options are for perimenopausal women?
Absolutely. So I have to say, I'm going to put this out there, and I say to my patients that come in, like, perimenopause is often more difficult to treat than
Mm,
menopause, right? We are having these hormone fluctuations. It's hard. It's just hard. It's just the way it is. So because it's not a cut and dry issue, it's not just our hormones are down, and if we replace them, we'll be fine. Because sometimes our hormones are up. And so, you need to keep that in mind too. So, and even when we sort of raise, let's say if we're using MHT and we're giving estrogen and or progesterone and we raise our baseline of estrogen, you're still going to ovulate, you're still going to have cycles, and your hormones are going to fluctuate. And so if you're somebody that's very sensitive to the fluctuation in hormones, you may still have symptoms taking
right.
MHT. So MHT, I want to make this clear. MHT in perimenopause is not an 100% treatment. So
Okay.
it's not a guarantee, I will say. I mean, it works well for many. It works well for partial relief for some. And for others, it doesn't work because of those fluctuations if you're incredibly sensitive. So,
Okay.
it can help sometimes, it can cure other times, but not always, because of the fact that they are not enough to take away the cycles. And
Right.
so sometimes, if you're really struggling through cycles, the fact of having cycles, I brainstorm with my patients about ways to stop cycling. If it's enough to affect their functioning, affect their quality of life. So, the mainstay way of doing that is the birth control pill.
Hmm.
That being said, at this stage in the game, many women either have had a lot of negative effects of the birth control pill in the past, or they just don't want to. And so it's always a very informed and, respectful conversation about the patient's wishes, because yes, the pill is an option, but I also get a lot of patients come to me that say their provider told them that the only option is the pill, and I didn't want the pill, and that was
Yeah.
it. End of conversation. So the pill is definitely the option. The pill works because it suppresses ovulation, natural ovulation. And so if you're being tortured by your cycles, you don't have to be tortured by your cycles. We can suppress those cycles and keep an even level of hormones daily. That being said, like I mentioned, some people just cannot find a pill that they feel good on. We try and try and try and try, and it just doesn't work. So it can be difficult for some, and others just don't want them.
Hmm.
They don't want synthetics, although now we have some pills that are more natural versions. Do we know if that's scientifically better for certain things or not? Not so much, but at least there's options. Options are wonderful. For really severe cases, I mean, I am the kind of person that thinks outside the box. So this is not typically medically indicated and not, what we do on a normal basis, but like there are other ways to suppress cycles for somebody that really is suffering. You could basically shut down the hormones and add
Right.
them back. Now, this is not standard of care. Don't go asking your doctors for this, but there are lots of options.
Sure.
And that being said, like you mentioned before, about contraception. So we always have to remember that there are lots of options for contraception. So, I do hear many, even, many people out there discussing, okay, so there's sort of two main options if you need contraception. One is the birth control pill, and the other is an IUD, which probably is a wonderful option. It's one of my favorite options, and the option that I use myself, a progestin-containing IUD, because we have to protect the lining of the uterus. And you can use a patch if needed for or some form of estrogen on top of that. And that would be MHT. And you also have excellent contraception and excellent protection of your uterine lining. And many continue that well into menopause. That's still an option into menopause, even when you don't need contraception. That being said, typical MHT is still an option. There are other forms of contraception if we need contraception. Condoms are an option.
Yeah.
They're not the best option, but we're not
Yeah.
18-year-olds.
Right.
You're consenting marriage adults that you understand the small risk. It's a contraceptive option. So is permanent contraception, right? A tubal ligation or self-injectomy can reduce your risk of ovarian cancer. Some great benefits from that. It's a surgery, so you're putting yourself through surgery, but it has other benefits. Vasectomy.
Yes. All in for vasectomies, everybody.
Vasectomy is
that's a
highly
terrific
effective. It's
option.
an outpatient procedure done under local anesthesia, in and out, no issues. Make sure to get it checked, ladies and gents. Make sure to get it checked later, because there's some whoopsies from not getting it checked and to confirm, but excellent form of contraception. So there are lots of
Thank you
options
for
out
that,
there.
Dr. Mandelberger. I see, I have to go back. I don't know. I can't believe we're at a half hour already. I hope that, are you able to give us just a few more minutes? Excellent. Thank you. I'm seeing lots of questions. I saw questions related to MHT and bones. Could you speak to this? Because it is definitely yeah, please.
Huge.
I'll let you go
So,
all in on that.
So MHT is indicated for the prevention, like by FDA, right? Like all the officials indicated for the prevention of osteoporosis.
I know exactly what you're saying. And I appreciate
I know
it.
you do.
Yeah.
It is FDA approved for the prevention of osteoporosis, which is enormous and is underappreciated and is a big deal and is a major killer of women.
Yeah.
I mean, it's harder for us, especially us millennials,
Yes.
to think about that, because it is hopefully far away, but it's not as far away as you might think. I mean, I test women early, either in the late perimenopausal or early menopausal, as a baseline. I find osteoporosis sometimes. We're already there.
Hold that
In other
thought,
times,
Dr. Mandelberger.
yeah.
I just saw someone say, "What is MHT?
Oh, I'm
Menopause
sorry.
hormonal
Yeah,
therapy." It's what was once known and sometimes still spoken as HRT, or
yeah.
hormone replacement therapy.
Thank you.
Sorry. Thank you.
Sorry about the
No,
clarification.
no,
Yes.
no, no, no.
The
I just
new
saw
the
it.
new
Yeah.
terminology
Yeah.
to use
Yeah.
MHT, because it's not replacement, right? When you're menopausal, the natural process is there's no hormones, or very little at least. And so we're not replacing it. We are using it as therapy for various reasons. So it's menopausal hormone therapy. So bone prevention, I mean, it's huge. Fracture, something like I'm gonna get this data wrong, but 20% mortality within the first year, or 10%, something major, and then even higher within 10 years. The 10-year mortality from a fracture,
Right.
not due to other causes, is humongous. Hip fracture, that specifically. So it's a major killer. And even if not a killer, so we talk about longevity, but we also talk about lifespan, we talk about health span.
Right.
So let's say you break a hip or break a bone, and it doesn't kill you, but it severely alters your daily functioning. I mean, if you can't do the things that you enjoy, that's not a good quality of life. So it's a big, big factor that is underappreciated, and a wonderful reason to use MHT.
You just reminded me, Dr. Mandelberger, about a conversation I've had with actually every urologist I've had a conversation with has spoken about bone health and vaginal estrogen, which is an interesting conflation of things. But what they have gotten at is the importance of vaginal estrogen as it relates to women having to get up in the middle of the night in the dark to go to the bathroom fall, have a, I know, the
I'm like,
connection was coming. It was
yeah.
coming. So could you speak about vaginal estrogen and sort of when a millennial might consider that? How would they know it's time?
When you feel like you're ready to devote 2 days a week to vaginal care, then it's time.
Okay.
There,
Okay. I love
there's
that.
no
Yes.
there's no right or wrong time to start. I mean, I would say not the wrong. It's never too late, but like if you're in menopause, I am a big believer that this is
Yeah.
prophylactic care. I think vaginal estrogen for
Talk
almost
to
all.
us about that. For someone who doesn't know, why am I worried about now vaginal estrogen?
So many things. So genitourinary syndrome of menopause is all of the changes that happen in the vulva, the vagina, and the urethra, and somewhat bladder changes related to menopause, which I can go on too long talking about why that happens. But this is something, hot flashes, things like that, mood changes tend to get better with time. Okay, if you did nothing, most people significantly improve those types of symptoms over time. Genital urinary syndrome of menopause gets worse over time, almost invariably. And then, it gets worse. It's not completely reversible. It may be partially reversible, but it can cause serious issues. Um, Not only sexual dysfunction with pain with intercourse due to dryness and stiffness of the tissue, more likelihood to have injuries to those tissues and difficulty repairing those injuries. You can have increased frequency of UTIs, which is a major killer of women, especially
Yes.
elderly women. You can have, now it's not a cure of all UTIs, but it does decrease the frequency. It can help somewhat with urinary frequency. Again, it's not like the mainstay of treatment for those things, but it does help urinary frequency, vaginal, a little bit of vaginal prolapse. It can help those things, stress incontinence. It can help to a certain extent. But if you would like to have a good, healthy sex life into later ages, your vagina needs a little help.
Right.
We need a little support of the estrogen. It maintains the elasticity of the tissue. Some people are like, I'm not dry, I'm not dry. That's great, but your tissue is not what it was. Even in your 70s, people feel fine, but their tissue has changed. It is atrophic. That's the word people don't like to hear, but it
Yes.
is. It's lost its blood supply, it's lost its physical thickness, and it's lost its elasticity. And these are crucial roles for the vagina.
And my understanding as well, and correct me if I'm wrong, is that the vagina is sort of like an accordion, and it's doing this, and it's plump, and it's juicy, and it's able to do this,
Yes.
and then that begins to shorten, and which is one of the reasons, in addition to dryness, that sex can be quite
Right.
painful. Intercourse can be quite painful.
So think of a sock, right? A fresh sock that you get, fresh out of the package. Oh, it's great. It's so stretchy, it's soft, it's perfect, right? But after bleaching it and putting it through the washer and dryer, not that we're bleaching our vaginas, but
It's
like
it's a
imagine
little
the sock
wilty. Yeah.
after it's like been
Yeah.
through it, right? It's your probably your husband's sock who who refuses to get rid of it.
Right.
But it's stiff now, right? It doesn't have the bounce back. It doesn't have that same elasticity over time. The same thing happens to, and it's more prone to, getting a hole in it
Sure.
and things like the same thing happens to our vagina. It loses that elasticity. And so if you're a crucial part of sexual function is the elasticity of the vagina. So when you're in the mood, your vagina becomes elastic. It actually, emits some hormones to create those changes, and that does not respond after menopause, and you're just left with a very sort of stiff vagina. And trying to have sex with a stiff vagina can be really painful. I hear all the time this. I hate this terminology because it just makes me feel horrible for the patient. But razor blades razor
Yes.
blades is
Terrible.
like everybody talks about razor blades in the
Yeah.
vagina. It's terrible.
Please get yourself vaginal estrogen. And if I just may insert alloy here, that you speak with a menopause trained practitioner like Dr. Mandelberger, who is not an alloy practitioner, but can speak to this as well as all of our doctors can. If you are unsure sort of where you are on the perimenopausal path to menopause, please do speak to somebody who
I'm gonna
is well versed and well
I'm
trained.
gonna answer
Um,
J Dag. No, you don't. You don't have to use progesterone for just topical localized estrogen?
Awesome. Do you
Good question.
want to tell us what that question was? Because you're
So,
seeing one that I didn't. So go
oh,
ahead.
okay. When you're using estradiol for the vagina, do you need to take oral progesterone? So if you are using it for just localized vaginal therapy, you do not need progesterone to protect the lining of the uterus. Good
Terrific.
question.
Thank you so much. Just a couple more
Sure.
questions, Dr. Mandelberger, and then actually, you know what? If I might just look back, I want to make sure that because I didn't see the question that you just answered. Someone's asking, since being menopausal, my libido is not there. Will vaginal estrogen help? This is an interesting question. Can you
It
speak
is.
to that?
It is a good question, and the answer is maybe. So the libido is a complicated
Yeah,
thing. There are, which doesn't mean it shouldn't be treated or it can't be treated, but it is complicated. We use what they call it the biopsychosocial model, meaning there are biological reasons, there are psychological reasons, and there are social reasons, right? Relationships and whatnot. And so, if at least part of the lack of so for one, let me back up. So using vaginal estrogen will help some of the blood supply, will help some of the elasticity, and will help some of the actual engorgement of the tissues that can happen during sexual arousal and pleasure. So some of that may come back, and sometimes you're right, that might be all you need to get what you need back, as well as if pain is a factor and we are improving sexual pain, if that from your brain was like, please no,
yes,
because it's painful. If you remove the pain, that might help significantly with your libido. That being said, it's not, your organic sort of natural desire, probably not, right? It's not so potent for that. But if it's related to any of those reasons, it very well could help. And I usually tell my patients that, like, let's see what, this first regimen, either vaginal and or systemic estrogen or progesterone therapy, if we're using those, let's see how that does for libido and go from there.
terrific. Thank you so much for that. Um, what's one mental, I'm just circling way back to mental
Sure.
health stuff because
Yeah.
I think
I'm
you
glad you
kind
asked
of,
because there was something I wanted to tell you about. Go
okay,
ahead.
good.
Ask your question.
No. I think that for many women, a mental health component is sort of the first and
Yeah.
loudest
Yeah.
symptom, if
Absolutely.
you will, and it will often get um, tossed in SSRI, which
Right.
I do not say lightly. SSRIs absolutely have their place, and I'd love for you to speak about that
Absolutely.
as well.
Yeah.
But I want you to kind of spend a little time in the mental health piece, if you would.
So, especially if we're on the topic of perimenopause and sort of millennial age women on the earlier side. So, one thing I want women in this age group to know, especially if you're mothers who have carried children or anybody that's carried and delivered a child, um, there is a humongous correlation between postpartum
Mm.
psychiatric issues, whether it be anxiety, depression, or even psychosis, and menopausal, same thing. Okay, so recurrence of these issues in menopause. If you had postpartum XYZ from a psychiatric standpoint, you have a pretty high, not 100%, but you have a high risk of those recurring in menopause. And so I want all women to recognize that so that you can look for the warning signs very quickly. And believe it or not, I mean, it's not standard of care for hormone therapy to be used as treatment for psychiatric, but it works.
Yes,
It works. I
and
mean,
I
it
would
is
love it
hormonally triggered.
if we could get there because I think about that, my own postpartum blues, my own sort of history of depression in my younger years. I was completely teed up to be affected emotionally, mentally by fluctuating hormones. And
Right,
had I have stayed on the pill, because I was one of those patients like you've had, who've said, I really am done with the pill. I don't really want to be on the pill. I've been on it
right,
for 20 years, right?
right.
But if I had been able to transition from the pill to MHT, I really
Would
believe,
have
in
been
my
smoother.
case, certainly,
Yeah,
yes, for
yeah,
sure, for
yeah.
sure.
Um,
Um, Go on. I'm sorry.
no, that's okay. So, I mean, I think that was my major point is
Yeah.
I really want women to recognize that and that, and I'm like I mentioned before, you know, estrogen is not treatment for depression on a large scale, right? I mean, that doesn't really make sense, but if you're individualizing treatment and it is clearly triggered by these hormonal changes, you very well should consider it as treatment. And sometimes, so I had a really, really sad case with severe psychiatric related to hormone changes. Sometimes these things supersede other issues. Okay, if you are non-functional as a human being, you have to, and it's, you know, you have to take some risk. Like, even if the MHT, you have excess risk for other reasons, it might, the risk, benefit may outweigh risk for you for certain cases. So we always have to weigh all of these factors.
Thank you so much for that. That's so, so helpful. If anyone's been following me for any amount of time, they've heard me say at least 5 times, refer to this New York Magazine article from several years back that was titled Midlife Psychosis. And it at the time, it terrified me, quite
It's scary.
honestly.
Yeah, it
It's
is scary.
very
It's
scary.
rare. It's
It
rare.
is extremely rare, but to hear you sort of say that you've experienced this as a physician
Yeah.
with a patient,
Yeah.
that it's that important, to be aware of,
Yes.
I think, right?
Yes.
That things can show up mentally,
Yeah.
emotionally.
This particular patient and her partner did not know to expect that. And, you know, luckily they identified it relatively quickly,
Wow.
but they didn't know that it was because this patient was going along just fine without meds for years and years,
Wow.
and then had a major
Oh,
recurrence. Really sad. Yeah, really sad.
thank you for that. Before we wrap up, I can't believe how long this is. This is
I could
fantastic.
talk forever.
I love it. I love talking to you. And I'm so, yeah, you're like a natural. This is your first live. Everybody, this is Dr. Mandelberger's first live. She came
Hi,
to us.
Mom.
I'm so, hi mom. Hi mom. My mom might be on here too. Um I saw someone talk about essentially like why do I need vaginal estrogen if I'm already on the patch? That is really important. Can you please talk about systemic versus local?
Yeah, so the best treatment for genitourinary syndrome of menopause is local topical treatment at the vulva and the vagina. That being said, I do have patients that respond to systemic therapy, and so I would never say you have to if you're on systemic therapy. But it's hard to tell if you're not floridly symptomatic, like right off the bat, it's not obvious symptoms. It might be hard to tell if it's helping that or not if we're using it for prophylactic reasons. So, you know, I don't think it gives much harm, except for, I always tell my patients, it's the harm is that it's like another thing to add to your plate, you know, which is not
Right.
nothing for us. We
Right.
got a lot,
No,
most of us.
that's a good point,
Yeah.
but don't
So,
skip this
you
one.
know, but just like your skincare, if you do any skincare routine, now we need a vulva vagina care routine.
Yeah.
And it's twice a week. It's not so bad. But that's really the issue. If you're like, I'm really just not going to remember, and it's going to be an issue, then all right, let's see how you do on the patch or whatever systemic therapy alone. If it's a no big deal, I would say might as well throw in some. You can decrease the dose a little bit and still use it.
Awesome. I was sitting there grinning like the Cheshire Cat because I'm watching all these really lovely comments coming in from people about you. So thank you extra. Um, there's so much more to get into, and there's so much more to get into sort of more deeply. We are going to have Dr. Mandelberger back. I believe we scheduled November, December. We're going to be talking about ADHD, which is near and dear to your heart
Yes. Yes.
personally, and in terms of the content and conversation that you are ushering along. But ADHD and perimenopause, all of it, we're going to look forward to next time. But right now, is there anything that is like gnawing at you that you want to make sure you share with us here?
I think the big ones was, I really wanted to get out the postpart, you know, your history. And by the way, for women that may have not have had children, another thing you can look to is how how you have responded in the past to like PMS symptoms. So that's another sort of fluctuation in hormones. So if you have severe something like PMDD, which is premenstrual dysphoric disorder, which is a more severe form psychologically of PMS, then you might also be at increased risk for psychiatric issues in menopause.
Dr. Adrienne Mandelberger, I saw somebody ask, what is this doctor's name? She's so wonderful. That's who we're talking to. For
Dr.
those of
Adrienne
you,
Mandelberger,
I
it's a
saw,
mouthful.
yeah, somebody, no, somebody asked, is this recorded? It's alive, so it will live on Alloy's platform, it will live on mine, it will live on Dr. Mandelberger should she choose to accept the collaboration. Please remember, perimenopause is a transition. It's not an end. It's absolutely something that you can prepare for. I'm
Yes.
thinking about the silos that Dr. Mandelberger brought up: nutrition, sleep, stress management, exercise, MHT, birth control pill, vaginal estrogen, mental health component, the buckets of cognition, mood, anti-inflammation, metabolic health, but most important, Dr. Mandelberger, you wanted millennials to know that educating themselves was the sort of the real thing that can be done, the most empowering thing they can do.
Yes.
Most of all, you want them to sort of be left with that piece. Is that fair?
Absolutely. And just to sort of plug my own thing for a moment, on that note, I have a course coming up. Are we
That
in
was going
October? No, next
to be my
month.
last question. How can people find you, Dr. Mandelberger? Tell us.
So I have a course that is geared for patients, right? It's great for millennials, but it's valuable for anybody that wants to learn more about all of this. And so you can find it at All Things Menopause, which is all-things-menopause.com. It's called the Discovery Series. It's starting on October 16th in the evening. And it's a 5-part course, and you'll get a lot of great info.
Terrific.
I am located in my private practice on Long Island in New York, and I'm licensed in the state of New York, and we do practice telemedicine as well. And I'm on Instagram here at Dr. Mandelberger.
Yay! And you're wonderful. Thank you so much. I'm
Thank you so
so,
much for
so,
having
so,
me.
it was an absolute pleasure to speak with you, as I knew it would be. Thank you to everyone who joined. I'm sorry if I missed questions. The fact that you saw one that I didn't makes me a little nervous, but I hope we got to most of them. Looking forward to speaking with you again, and thank you. Just
Thanks so much for
terrific.
having me. This was great.
Bye, everybody. Thanks.